29-year-old female, but history of heavy alcohol use, they say since childhood. So that's the background. And this came to us with an outside CT, which I'll show you in a little bit. But probably the MR is more helpful. So T2s, not a subtle finding, but I'll just keep scrolling. Pre-contrast T1. This is early post-contrast. Arterial phase. Portal venous phase. And this is more like a 1.5 minute delay. And then this is a 15-minute delay. And then here's the high B value diffusion. Here's the ADC. And then the MRCP, obviously this has been biopsied 3 times now, 2 times, 1 time through EGD, 1 time EUS, and 1 time CT guided. And the CT also shows similar findings. So any thoughts how we would have read this? And it's a short history. Her LFTs have gone up significantly only in the last 3 weeks or so, ever since this CT was taken.
Yeah, Manjil is asking the same question I was thinking, is the portal vein out? It looks like
Yes.
there's a lot of like delayed enhancing soft tissue throughout the porta. The portal vein is out. Doesn't look like totally classic, just cavernous transformation.
No, it did not. Didn't see any tangle of collaterals at the portohipatus, but the portal definitely looks like it's gone. This may be like the ghost of what may have been the vein.
Manjil is asking about, well, first he said intravascular HCC and now lymphoma, pseudotumor, and IgG4. All excellent.
All good thoughts. So we ran all the tumor markers. AFP was normal. CA19-9 was normal. So I will tell you what the biopsy said. 3 biopsies were done which showed no definitive evidence of malignancy. So all tumors are out.
Did it show any inflammation?
They did show inflammation, and so the biopsy findings were just periportal fibrosis with mild chronic inflammation. So those were good differentials to start with. If she is an alcoholic, if she has cirrhosis, definitely worth thinking about infiltrative HCCs or cholangios, but tumor markers were negative and the biopsy didn't support that. IgG4 was another great thought. It looked a little too extensive. Like the typical one we describe is the IgG4 related sclerosing cholangitis, which is very periductal infiltrating. We know it causes long segment, smooth strictures, and the soft tissue is a dominant feature. In this, it looked more than just around the biliary ducts. The entire hepatic hilum and all the hilar structures are encased, but definitely still on the differential. Some weird lymphoma, leukemia, chloromas, which they've reported, but again, the biopsy did not support it, and really no other nodal disease anywhere. One of the
lymphoma might have had like more severe restricted diffusion.
It would be definitely a lot more restricted. What do you guys think about the pancreas? To me, it looked a little bulky and not super lobulated. So still definitely kept IgG4 disease spectrum. And then IPTs, which are inflammatory pseudotumors. They now describe the lymphoplasmacytic variant, which they say can be a perihilar mass, as opposed to the classic intrahepatic IPTs we know, which are more of the fibrohistiocytic type masses. But again, the lymphoproliferative ones are in association with IgG disease also.
I like inflammatory pseudotumor.
Something that has high fibrous tissue content is what we came up with. The way it enhances low signal, it tracks around the gallbladder fossa, smoothly encases everything. She has other features of portal hypertension, splenomegaly, some varices. So only other thought was, is this some weird type of cirrhosis related fibrosis that any of you have seen? Or
No, I've seen something like this. I feel like we never got an answer,
right.
but I have nothing else.
So those were basically the differentials. And I just want to share one more screen. As I was reading about this topic, there were a few other things, few other entities that they described, and I'll share this screen. So periportal infiltrative masses, we spoke about all the malignancies. In a post-transplant patient, PTLD can have a similar appearance. Langerhans, something like this would still be in the differential also. Extramedullary disease, we certainly see this a lot in our institution. Extramedullary hematopoiesis, but no reason to have any underlying causes for that. So some unusual conditions I came across were these nerve sheath tumors, leiomyosarcoma of the portal vein, which all would be more mass forming and not like very infiltrative and wouldn't have this progressive enhancement type pattern and would restrict a lot more. And then of the mesenchymal tumors, these are sort of the differentials. We spoke about the two types of IPTs. So this was a case of IPT we had published last year. So this is more of that mass forming intraparenchymal fibrohistiocytic type. So at PATH, they will find a lot of eosinophils also in these, as opposed to the lymphocytic ones, which have the IgG4 laden cells. And then some more literature examples of plexiform neurofibromas. Like if you put this anywhere else in the body, it will look like NF. The lobulation, bright T2 signal are all typical, which our tumor doesn't have. And then some examples of leiomyosarcomas, again, more very heterogeneous mass, like this one is encasing the artery. So these were just the literature examples for the differentials. So they are repeating yet another EGD biopsy on that patient. And I don't know if you guys have any other intelligent suggestions, I can take it to my GI folks.
I'm not seeing anything on the chat box. I think you got it covered.
Okay.
Is she a transplant candidate? I know the portal vein was out. Was the SMV, like, was it?
We couldn't see an SMV either, and we've not yet discussed her in the multidisciplinary liver conference. She's a very heavy alcohol drinker.
Yeah.
So that's mainly her social issues are mainly unless she goes to AA and does all that stuff, she won't even get cleared.
Yeah.
So if the fourth biopsy shows anything, I will definitely let you guys know, but it's just an interesting case and I just didn't know what else we had to cover from the radiology standpoint.
Yeah, let us know. If
All
it
right.
I guess like you might not even get that IPT diagnosis is hard to get unless you have like the surgical path, you know?
No, when I spoke to the GI pathologist and she said all she really sees is fibrous tissue and like bland fibrous tissue and nothing else.
Yeah, interesting.
So yeah, thank you for all the input. I will, if I find out, I'll let you know.
Okay, good. Nanda, do you want to go?
Okay, let me share my screen. All right. So, gosh. All right. So this case took a very unconventional path, and I thought it'll be interesting to share. So anyway, a 51-year-old patient, history of cirrhosis, and she was followed with MR, screening of HCC and all that stuff. Anyway, so she had clinical complaints of dysphagia, and so they started out with an upper GI, and they saw this smooth compression of the esophagus on endoscopy. They did an endoscopic ultrasound, and they thought this was a cystic mass, although I feel like the gain is too low. So I think they should have increased the gain. So I used my sophisticated PowerPoint software. So I feel like there were some low-level echoes in this mass. Anyway, this was called cystic. So they asked for an MRI. So this patient went from upper GI endoscopy to an MR. And so we did do the MR. I thought like my windowing was better than how it looks. Okay.
It's okay. We can see it.
So you can still see it, right? It's just too dark, but this was like this was kind of like a T2 intermediate mass right here. Maybe when I was like playing around with the contrast on the PowerPoint, it kind of changed to too dark. Anyway, so this was like, this is the mass. It was on T2s. It was kind of intermediate, not as dark as it is seen on this image. And there's one more thing I want to do. Sorry. Also on the pre-contrast, this is the pre-contrast image. It was T1 bright, and post-contrast images, there were so on the endoscopy, they did not FNA this lesion because she also had varices and they were worried she'll bleed. Some of these could be those dilated veins, or it could be the enhancing areas within the mass itself. And then, so these are the subtractions.
Nanda, your sound is kind of going up and down a little bit. So if you can just hold your speaker close to you.
You know what? I'll do that. I just removed it from the computer. Can you hear me better?
Yes.
Okay, awesome. So yeah, so this is the echogenic, T1 bright mass. This is kind of, I cannot really show the esophagus really well on these mass images, but it did appear as if it's enhancing. Subtraction images, there was some, so this structure over here is actually the esophageal lumen. It was pushed to the side, enhancing portions. So anyway, so we ended up calling this as a solid mass because of such smooth.
Two observations. The T2
Right.
hypointensity was making me think of like a leiomyoma or some kind of muscular thing.
Right.
And this kind of nodular enhancement is making me think also of a hemangioma.
Oh, yeah.
About GIST tumors of the, as like submucosal solid mass.
Right. Yes, thank you. Yes, so the enhancement was like kind of throwing us off because we did, my thinking was same too, that because of that hypo intensity on T2, I was like, this is like more of a muscle tumors, but what are these enhancing areas, right? But apparently they did see a lot of varices on their endoscopy too. So this could be some of those vessels which were running right next to them. But anyway, so we did give all the differentials on the MR, and this patient ended up getting a CT. That is the way it should be. So on the CT, it kind of looks classic for a leiomyoma. She does not have tissue diagnosis, but these calcifications, they're considered like pathognomonic for leiomyoma. Would you just call this a leiomyoma and leave it, or would you still give differentials on the CT as well?
I didn't know that that was pathognomonic for leiomyoma, and I know that GIST can have calcifications, although it wasn't enhancing as much as it just should.
Yes, yes. So it was not enhancing as much as it just should. That's right. So I kind of pulled up the literature, and apparently the presence of calcifications within this mass is pathognomonic. And it was like in a bunch of literature. So just because of those calcifications, and it's also like smooth marginated mass, we ended up calling this leiomyoma. She may not get a biopsy done, but that's kind of my final diagnosis at this point.
It's kind of interesting because I don't understand how they can say it's pathognomonic when both GIST and hemangiomas can have calcifications in it.
Yeah, that's right.
It's like confusing to say like that. If you say pathognomonic, you're saying there's nothing else that it could be or something. But
that should have calcifications, right? Yeah, no, I saw this pathognomonic on the Radiopedia, which is a great source. But then I also looked up other sources, and there were like several articles which mentioned calcifications as one of the very important findings to diagnose leiomyoma. But
it can be maybe very suggestive, but not necessarily completely. Manjil is saying also neurogenic tumor and hemangioma, which I think are both kind of in there. I think probably all of those are, especially leiomyoma and hemangioma, they won't do anything about potentially. So the only thing is concerned about missing a GIST, and it should have been enhancing more. So we don't think it's a GIST, but I think, I don't know, here, as long as they have a clear route and it's not going through a varix, they probably still would have biopsied it.
Yeah, I think they still should. I completely agree with you. I think on my MR, I gave all differentials. But on the CT, I am favoring more of leiomyoma. But I think those points were useful. If this patient does end up getting an FNA, I'll keep you guys posted. That's all I have.
Cool. Thank you. Okay, and I know Victoria and Manjil both have cases. So Victoria, want to go next? And we can't hear, I can't hear you well. So if you can just
hear me?
A little bit better, yeah.
Is it better?
Yeah.
So I have two kind of themes. So this is one case. It's not a diagnostic dilemma.
Okay, wait, can you move your microphone a little closer? Sorry.
Can you hear me?
Yes.
Okay, I'm literally speaking to it.
Yes, perfect.
Okay, so this is not a diagnostic dilemma. So you can see the patient has a penile fracture. And the reason I'm showing, I'm going to show two cases which are very straightforward and one case which is not. So you can see in this case, patient has a, this is a shaft, and you can see that there's a discontinuity of one of the corpora. You can see the Bach's fracture is, Bach's fascia is disrupted, and you see the hematoma. It's intermediate signal intensity on T1 and kind of low signal intensity on T2. This case was done without contrast, or with contrast. Yeah, without contrast. So we don't know, in terms of active bleeding or not, but just based on the imaging characteristics of the, signal characteristics, this is like an acute blood, right? Intermediate and low. Another case.
That's a really nice example of a rupture.
Right. So another case is also very straightforward. The same situation. You can see disruption of the penile shaft. You can see the hematoma here has a very different signal characteristics. It's also intermediate on T1, but now it's brighter on T2. And in this case, we actually gave contrast, and you can see that we actually see active bleeding. So this is a rare instance of hyperacute blood that we see on MR. So this is actually hyperacute. So very similar to the first case. You can see, this is very straightforward. Disruption of the shaft, disruption of Bach's fascia. You can see a hematoma. You can see tremendous edema of the penis. So very,
Victoria,
very.
did you guys start with ultrasound and it wasn't definitive? Because I've had cases like this, but mostly on ultrasound. And some of them are hard, but some are pretty easy by ultrasound.
This one straight to MR. These two cases went straight. So our urologists really enjoy MRs. So the two cases, these two cases did not have ultrasound. The third case I'm going to show you also didn't have an ultrasound. And this one is a much more subtle, or much less straightforward case. So what happened? So the other two cases, the story is very classic. There's in the middle of sexual activity, the person hears a pops and a tremendous pain, and that's what happens. And there are certain positions or activities that kind of predispose you to this. This was a very different. This is an older gentleman, and his story is that he turned in a certain way during the sleep, and then tremendous pain with detumescence. I don't know if I said it right, but anyway, as his erection went down, he in pain. So you can see that the appearance is very different. So you have, in the other two cases, the hematoma was in a shaft and the edema was in the shaft. Here, you can see that all the inflammatory changes are centered kind of like within the soft tissues, superior to the penis. And this is along the suspensory ligament of penis right there. Not much in terms of the hematoma in the shaft. Another thing that I want to point out, and I don't know the answer actually here, so I would love any ideas. You can see that the dorsal vein is quite irregular. And if we go back to the other cases and look at the appearance of the dorsal vein, it's much more smooth. You see how smooth it is, right? Very, very smooth. And this is the region of the suspensory ligament of penis. But now you can see that the in this unusual case, you can see that the vein is very, very irregular. Unfortunately, we didn't give contrast because actually, you know, we don't usually need to give contrast for penile fractures. We usually don't give. So anyway, so here it is. On the physical examination, the ecchymosis was mainly in the peripubic area or in a mons pubis area rather. But so I was actually planning on just dictating this as a rupture or strain of the suspensory ligament of penis and you know, question whether there was some injury to the dorsal vein of penis. But then if you look in the axils, you can see some of the inflammation does go into the penile shaft. And I'm actually not sure if there is a penile fracture. You can see that there is some edema here in the shaft. I don't think the box fracture is disrupted, but anyway.
Do you think, would the dorsal vein normally show a flow void? Like, is there any possibility it's thrombosed here because of that lack of flow void?
No. So here's, you can see in the other two cases, it's bright on 2-2. So it's okay to I don't think, based on the sequences we acquire, unfortunately, we can't say whether or not this is thrombosed. So I had to hedge and say that I don't know actually. So BTFE, unfortunately, is not high enough. Like here we would have, you know, BTFE would be useful here to know whether or not there's flow, and you can probably make a you know, a comment that there is some brightness there, so it's probably not completely thrombosed. But I don't know if this is good enough to make that determination. And I actually had to tell him that I don't, given this irregularity, I don't know if the vein is thrombosed. I don't know if the vein is damaged in some way. So I don't. So
I feel like their ultrasound would be helpful. Sorry to keep harping on ultrasound, but that would clear the vein, you know.
Right. They didn't really, they weren't as excited about it as I thought they would be. So
yeah,
I
just be injury to the suspensory ligaments.
Right. So actually I ended up calling my one of my urology colleagues and asked, because I deduced that it has to be some sort of suspensory ligament injury. And I asked her, you know, if this happens, and she said, yeah, we've seen it. It's very unusual. It's much more common to you know, to have a fracture of the penis. Now, interesting feedback that she got me is that the story that the patient provided just cannot possibly be true. She said that you just cannot possibly have enough force and damage just by turning, you know, somehow in your bed. It's just not possible to provide this degree of damage. So she's saying the patient is probably not telling the truth. Anyway, so I don't know if anybody has any ideas of how to definitively say whether or not there's a component of a fracture, but we ended up basically hedging a little bit and saying, well, there's definitely strain or rupture of the suspensory ligament. There's also very abnormal appearance of the vein, and maybe there's a component of shaft injury, but not definitive. They actually just discharged the patient without doing anything more than that. And yeah, so from what I understand, as long as the box fascia is intact, they treat these conservatively, and then they have to deglove the penis if there's a fracture with bug, and they have to like deglove it and fix everything. It sounds like a horrible procedure. So.
Interesting. I actually have a penile case as a follow-up. I don't know. Do you have more cases?
Yes, I have another kind of quickly.
Okay.
This was a 16-year-old girl who came in for right lower quadrant abdominal pain. They were looking for appendicitis, and you can see that the right ovary is quite enlarged, and you can see there's a big cystic structure in it. And the reason why I want to show this case is that it has a very, very nice, look at this beautiful depiction of the pedicle twist. So this is not a diagnostic dilemma. This is a ovarian torsion. But the pedicle twist is not seen in 100% of the cases. Sometimes it's hard to see, but this is probably the best pedicle twist that I've seen on the CT. You can see, like, you actually can see the twist, and you can see the thin slices actually show it much better. You can see like this nice twist. And then just as a couple of companion cases, this was another very young, also 16 or 17-year-old girl. And, benign cysts actually, benign lesions actually much more commonly associated with torsion. Malignancies tend to create some degree of fibrosis or some fibrous reaction around them. So that helps to tether the ovary in place. So it's actually much less common. The torsion is much less common with malignancies. And functional cysts are very commonly the cause of it. But this was an unusual case. This is a path-proven torsion, and this patient had also presented with pelvic pain, and she had polycystic ovarian syndrome. And you can see that it's very hard to figure out what's happening. You just see this big kind of funky mass. They took her to the OR just based on the suspicion and clinical history. And this was just a torsed ovary with polycystic ovarian syndrome changes. So this is the left ovary, and this just big thing is the torsed right ovary. So here, it's very hard. Like I couldn't find anything here that looked like a twist. So sometimes it's just difficult to find that. And the last case, I just wanted to show the twist on the MR. This is a pregnant woman with abdominal pain, and you can see here there's a big ovarian mass with T2 fat sad. Here we go. You can see that on the fat sad, the gross fatty elements. So this is a big teratoma, and you can see this kind of twisting of vessels here adjacent to it. So again, once you see the twist, this pedicle twist, that's a diagnostic of the torsion, but we just don't see it all the time. So you can see sometimes you see it better on different projections. So here you can see it nicer. You also see a little bit of ascites, which is also very common in patients with torsion. And then let's see what else. And here's another way to look at the twist. So those are my cases.
Nice. Victoria, do you know if they went and took that dermoid and twisted ovary out? Like, I was just wondering, like, as she's pregnant, like what they would do here.
Yeah, well, she's in second trimester, and if you have to have surgery while you're pregnant, second trimester is the way to go. But yeah, because she's in pain, so they actually took it out.
Mm.
Yeah.
Cool. I like the series, the companion cases.
All right.
Okay, Manjil.
Yeah, hey, how's it going? Let me just share my screen. This is quick. It's just a case that we saw today that we had a question about. So I was hoping to get some feedback. Let me do this portion. So this patient had a history of rectal adeno-CA. Can you guys see the screen?
Yes.
Okay, cool. So yeah, this patient had a history of rectal adeno-CA, and there was concern for some sphincter issue at an outside hospital. On the T2 here, you can see part of it, and then, I think we do struggle from time to time trying to find the actual cancer. So this was done on the outside, and there was a question of whether this represented the cancer, this T2 area on the mucosa on the right side. And they came to us, and we repeated the study, I think, as we often do. And then this is what we got. So the actual tumor that's 7 to 8 centimeters away, I'll show you first, just to get it out of the way. It was associated with an ulceration. So the person who read this kind of like, found this focal area of thickening that was about the distance that matched the colonoscopy and thought that that was probably the initial tumor with the nodule. The real question we had though was about the sphincter. And so here it's distended really well. And then you get down to the sphincter and, you know, this part of the sphincter between like 12 and 2 looks pretty good. But then the remainder of it is kind of grayed out and looked not different than the outside studies, certainly, but not of normal muscle sphincter intensity. I mean, on other sequences, like here's diffusion, here's the highest B value, you know, you don't really get a sense that there's a mucosal lesion there, nor do you see the sphincter abnormality. And then on the post-contrast, it was, here's the high res. On the post-contrast, you know, I thought that we could still see mucosal signature here and that it was enhancing pretty normally, but the sphincter itself did not look totally normal on the post-contrast either. Perhaps it's enhancing and a little bit irregular. Honestly, when I got to this, I kind of also, someone at the last second showed a coronal, which I'll show you all, that made me lean more toward benign, that perhaps this is a, you know, some sort of sphincter like inflammation, or could this be from maybe manipulation? Because here, I mean, you can see the internal sphincter really well, and it's just mostly edematous. She hasn't had radiation or any other prior intervention in this area. At colonoscopy, they did not see a lesion. The sphincter seemed normal, but again, the mucosa looks normal here. So is this a muscle issue? Is this another focus of tumor? It makes a big difference because of the LAR and the need to do a low anterior resection. So Stephen Eberhard's saying SAG. Let's take a look. So here's the SAG.
He's also saying edema, which I agree with. I'm thinking this is not a tumor.
That's kind of what we thought. So would you be good going along with an LAR at this point, or would you say biopsy that area? You know, because the LAR, if that is tumor in the end, like, you know, we're going to be in.
I mean, if that's tumor, then that entire sphincter is infiltrated with tumor, and they definitely would have seen that.
Yeah, that was kind of my thought as well. So
I would be comfortable.
Yeah, so Stephen, this is our sagittal. It's because of COVID and a variety of other reasons, this is the sag, so it's not a small field of view. But you can see it kind of has the same, you know, appearance. And then here is, oh, this is another axial. Here's another coronal. Like I said, it kind of does have that same shape, and maybe there's some edema in there. I've just never seen it like that, especially on the axial being, you know, so focal. So that's what we kind of thought as well.
Yeah, I guess you could always go back and just like talk to your surgeon about it and see how comfortable they felt about like visualizing the sphincter as they go in, you know?
We have been, and they don't feel comfortable because they're saying, you know, and rightfully so, they're like, we don't want to do an LAR, which is such an intense procedure for a patient who might even have tumor there. So the question there is whether to do a deep biopsy, which, you know, that brings its own risk with it as well. But, you know, I did kind of feel like this is probably benign.
Yeah, and their like rectal exam also didn't feel comfortable with that.
They didn't feel anything. I mean, there was no, we made up this tumor. You know, I mean, somebody made up this tumor from the beginning. You know, the actual ulcerated lesion is somewhere totally different, you know.
Yeah.
And maybe that speaks to this being benign as well. Like, what are the chances that you have sphincteric involvement in a non-contiguous tumor 8 centimeters from the verge, you know, probably.
Exactly, yeah, non-contiguous would be really unusual.
Well, thank you for that.
Yeah. Okay, I'm gonna show mine. Oops, you have the diagnosis there? Oh well. Okay. So this patient came in months ago with penile pain, and oh, Lakshmi has a case, yay. Okay, they came in with penile pain, and we thought their corpora looked a little bit abnormal, but we didn't see any focal mass. I can show you the other sequences. This was the sagittal. We thought it looked a little bit heterogeneous, and here it is here though, looks completely pretty normal. I can show you diffusion. Nothing really standing out. So clinically, the patient had a painful plaque, and they thought maybe, they basically thought clinically maybe he was developing Peyronie's disease. Peyronie's disease on MRI, usually you could see it maybe as a T2 hypointense plaque along the corpora, along the capsule here, but we didn't really think that we saw a definite plaque there. On CT, you could potentially see it as a calcified plaque. So patient went away and then came back 6 months later, and this is what it looks like now. So really dramatic kind of development of focal masses, T2 hyperintense, and we saw them basically on all the sequences. So, you know, even we showed this at our case conference, and, you know, we were looking at like even 6 months ago, nobody would have called it. And now you can clearly see that there's all these masses here. So just like really dramatic development of like multifocal penile tumor. So just a couple of points about penile masses. So this one turned out to be a poorly differentiated adenosquamous cancer. About 95% of penile cancers are squamous cell because they usually come from the skin of the penis. And then the next most common would be metastatic disease, usually from the GU tract. So some kind of urothelial cancer of the bladder or kidneys, and then some sarcomas. They metastasize to inguinal lymph nodes first before going to like pelvic and retroperitoneal nodes. The risk factors are age. So usually it's like 60, 70-year-olds, HPV, which this patient had, smoking, HIV, non-circumcision. So this one is one that is thought to be one of the causes, and it's thought because it leads to sort of accumulation of inflammatory debris and like just kind of irritation of the penile shaft, and then poor hygiene as well. So this leads to chronic inflammation, which can lead to the squamous cell carcinoma. And then adenosquamous, I mean, there's no way to tell this on imaging, but it's basically because it derives from both that squamous cell of the skin as well as the mucin-producing glands, which is the adeno part. It's more aggressive. You can also see it in all these organs. So I've seen some in the pancreas and also of the cervix. And these are, in the penile shaft, it's usually treated by surgery because although squamous cell is responsive to radiation, the adeno component is not. So for this patient, they're planning to do a total penectomy with a lymph node resection. Somebody's asking me, was the T2 signal of the penis not diffusely low in the first scan? I don't think so. I can bring it back up. Sorry, I'm having frame issues. Okay. So yeah, it was not diffusely low. It looks pretty normal to me, and definitely not like the focal masses that we see on the second scan. Okay. My next case is this one. So this was a lady who had Y90 at an outside hospital and came in with an abscess in the Y90 cavity. This could be just a regular Y90 cavity. Sometimes you get air in it because of the necrosis, but she was having like a white count and a fever, and she wasn't doing well. You can see she's like got anasarca and an effusion, and then this actually was like kind of an empyema here that they put a chest tube into. So she came from the outside hospital after the Y90, and so we put a drain into this Y90 cavity. And does anyone notice anything on this scan that you might want to be careful about? Go to the coronal. So I'll just point it out that the colon is very edematous, and it's kind of interfacing with this Y90 cavity here. So anyway, the people who put in the drain astutely were kind of noticing that there was a lot of sort of feculent material coming out of the drain, and so they put the drain in, and then they injected contrast. And you can see that there is a fistula with the colon here. So the contrast went directly into the colon. So yeah, Steve got it. So that's this Y90 cavity had fistulized with the colon. So I just had a couple of points about complications from Y90. So I was asking my IR colleagues, like, is this common? And they said, you know, this is why we do all these planning sessions. So before they do Y90, they'll do a angiogram, and they'll see what vessels are feeding the liver. And they want to confirm that there's no shunting to the lungs, because if there's significant shunting to the lungs, you can get radiation pneumonitis. But they also want to see that there isn't significant flow into the GDA, the right gastric artery, an aberrant left gastric artery that might come off the left hepatic artery, the phrenic arteries, etc. And if you do see any shunting to any of these other arteries, then you would coil embolization those, because you don't want the radiotherapy seeds to go into like the stomach or the colon. So the complications, the most common one is going to be a biliary complication. These are usually minor. You can get bilomas. Occasionally you can get cholecystitis, although for some reason the gallbladder is actually fairly resistant and does okay. The radiation pneumonitis, if there's a shunt, you can get ulcers in your stomach and duodenum. It's pretty rare to get something of your colon, but it seems like in this case, they're probably either the tumor was adherent to the colon, or that there was vascular flow to the colon and it developed this fistula. You can also get radiation-induced liver disease if you're redosing them multiple times. So they have to do this very intricate dose calculation. And then a lot of patients get this, which is just a self-limited syndrome called post-radioembolization syndrome, where they just get like fatigue and pain, but it's actually better than what they get when they have TACE. So that's the most common complication, but that's just self-limited. Roopa says, we have a case like this with gallbladder to Y90 cavity. Oh, so you had a fistula between the gallbladder and the Y90.
Yeah, same thing. Fistula between the gallbladder and treated radiofrequent Y90 cavity. Basically.
Actually, my IR guy, when we were talking about this, he was asking for cases because he wanted to.
Sure, I'll be happy to share.
Yeah, he just needed a few more to get. And if anybody has a cholecystitis, did yours start as a cholecystitis?
No, it was just a direct communication.
Yeah. Okay. And then this is my last case. So I don't have the full answer to this one, but actually I consulted Ivan Pedrosa at UT Southwestern on this one, and he immediately gave me more insight than I had before I consulted him. So this is a patient with multiple cystic lesions of their kidneys. And you can see that actually at an outside hospital, 2 of them had been ablated. So this is one ablation zone, and then this was another ablation zone. And this was the post-contrast. So that's just the ablation zone, but okay, you can see actually that we've measured a lot of them, but a lot of them have these kind of like enhancing septations to them. And my urologist was like, oh, I said, okay, we've got 15 different lesions here. A lot of them have enhancing septa. How many do you want us to describe? And he said, I want you to describe every single one of them, because I'm going to print out your report, take it to the OR, and then chip them out one by one. So I need to know where every single one of them is. So we were doing this. And then he told me that at the outside hospital, they read that there was some minute foci of RCC in these lesions. And then when the pathology was reread at our hospital, it was read as just atypical cells, but no definite RCC. And so then he asked me, would you guys be willing to biopsy these, because I don't want to go in without knowing that these are definite RCCs. So my question to you guys are, do you think, one, these are RCCs? Do you think we should biopsy one of them? Do you think we should be doing nephron sparing surgery, or do you have any other thoughts?
Aarti, we've been doing contrast enhanced ultrasound on cases like this. And I feel it's pretty recent, and it shows really good. So if there are a couple of examples. I'll pull them up next week. If there is washout, you can actually see enhancement and washout, and you can kind of diagnose at least some of these with like good diagnostic certainty.
Yeah, I felt like also these ones, I feel like there was definitely like thickened septations and that kind of thing. And if we had to biopsy one, like, maybe we could go for this one. I don't love biopsying like cystic renal lesions, but we could do it. But any other thoughts? That's great contrast enhanced ultrasound. We still don't do that here, so.
Okay.
The ones that are under 3 centimeters, I would probably just lean on observing, you know. But,
okay, great point. And why are you saying that? Because RCCs under 3 centimeters should be observed, or because of something else in this case?
because they're cystic lesions, they're not solid, and cystic renal carcinoma has a different natural history than solid. You know, so even the Bosniak 3s and 4s tend to behave more indolently than a similarly sized solid mass.
Great. Okay, good. And there's one more thing we need to bring up here.
VHL, if you have multiple renal lesions.
Yeah, perfect. So as soon as I sent this to Yvonne, he was like, VHL. And that had just completely slipped my mind. She didn't have a prior diagnosis, but she actually has multiple relatives who've had RCC, and she's now undergoing a genetic workup. But so he was pretty certain that these are going to be VHL. So I'll have to report back about the genetic workup. But that is something I felt I should have thought about in the beginning. And so multiple cystic lesions. And he said that even the ones that are simple cysts on MR are going to be RCC. Because basically there's just like this RCC proliferation going on throughout the entire kidney, which is why they get so many of these lesions. So even ones that like you can't say, oh, there's definite enhancement in it, they're going to be a little RCC. And then Steve's point is right on point, like especially for VHL patients, you want to kind of watch them. They have more indolent RCCs, and you don't necessarily start resecting them until the solid component is greater than 3 centimeters. So Yvonne said that's still a little bit controversial about where do you measure it? Like, is it if the lesion itself is 3 centimeters or just the solid component? But he said, as of right now, most people would favor that you would only measure, the solid component being greater than 3 centimeters. And then the other thing he said was that we don't use Bosniak for VHL. So I thought it was just interesting that, that these are all going to probably be RCCs. We don't need to biopsy it. We probably just need to watch all these lesions.
Yeah, once the VHL diagnosis is more or less established, they want to do all you can to prevent the person from being kidney less.
Yeah, definitely. Yeah. So we'll end up watching a lot of these. And then if they grow, that's the part that I didn't know, because if all of these are cystic, I mean, they'd have to get pretty big before like really the solid parts are greater than 3. But definitely we want to do like as much active surveillance as possible.